I request our program director, Ganesh Shanker, to introduce our eminent speaker.
A very good morning to all of you. I'm so much delighted to have all of you here on this very important session. Before introducing our guest speaker, I would like to say a few words about this topic. Depression is something which is very much pervasive, very much prevalent, yet it is overlooked. And why this topic has been chosen for IMA-CGP? Because every doctor of every specialty must know about the basics of depression. Because you see patients at your clinic, that patient might be having a lot of physical symptoms, yet the patient might be having depression as well. And any patient with chronic illness can also develop secondary depression. So it is of paramount importance to diagnose the depression at the earliest so that we can give a holistic treatment. It is not about just being ethical, it is also legal, especially when we are working during the era of Mental Health Care Act 2017. So without wasting much of your precious time, I now request Madhukar Medias to kindly introduce the speaker.
Good morning. This trip and this occasion is turning out to be more emotional than I had anticipated. As you will see in half a minute, Kanpur and some long-time friends in Kanpur have been a matter of deep personal satisfaction. But now to see Dr. Madhukar Katya, Dr. Dhananjay and Sanjay chairing this with my very good young friend Ganesh coordinating this whole thing is actually very emotional. But let me get on to, I'm sure all of you had interacted in one or the other manner, and for last few days it's been my thought that I cannot come to Kanpur and not talk about Dr. Nimesh. I mean, I don't need to say many of these things that all of you know very well, but besides these four colleagues and a few other colleagues sitting there, he was what he was, and a huge tribute to Mahendra, who I miss dearly, especially coming to Kanpur. Mahendra, be happy wherever you are. Okay. Let's get on to the business. I think not only Ganesh introduced very well, really briefly, the importance of depression, but I think it was Dr. Rashmi, right, the lady who introduced the session. She put it into it very succinctly. She said, depends on how you feel, how you think, and how you act. So the three aspects of depression, indeed, she covered, as we'll try and do in many slides, very well. But think about it. In last few years, we have had quite a few celebrity endorsements for mental health. Deepika Padukone, Virat Kohli. But go back a little, and many of my contemporary and slightly younger colleagues will remember great examples in creative arts for depression and other mental health problems. Gurudutt, Meena Kumari. सोचे ये कि अगर गुरुदत्त साहब यूनिपोलर डिप्रेशन के शिकार नहीं हुए होता तो शायद प्यासा और कागज के फूल फिल्में बनती। प्यासा एंड कागज के फूल पार्टली इफ नॉट लार्जली देन है डिप्रेशन। मीना कुमारी जी की पोएट्री और मीना कुमारी की एक्टिंग देन है उनके डिप्रेशन की। Too many examples. I know if you follow Leo Tolstoy, Vincent van Gogh, or Da Vinci, it is well recorded. All of these artists actually contributed a whole lot to that. So, the question is there a good relationship between creativity and mental health problems, especially depression? Yes, for sure. So, that can be one argument as to why should you treat depression at all. Why not leave persons to experience the depression so that creativity will work out better? Second, a lot of, in our field, all of us psychiatrists and mental health professionals, we have to also contend with a whole lot of competitors or collaborators, call it what you want and see them as you like, life coach, motivational speakers, and so on and so forth. Now, many of them, and especially the spiritual leaders, you will remember, would say that depression can be a very good experience for learning lessons of life. So why not let people go through depression a little bit? Depression can be a huge resilience building. Like I said on the slide, if you remember, one honestly unmatchable example for resilience and fortitude was Mahendra Saab. I mean, the kind of life that he went through and yet stood like a rock was unbelievable. So why not let depression be a resilience building experience? So I'm going to try, as Ganesh Shanker and we discussed, I'm going to try and share with you some reasons as to why treat depression, and then of course say how to do that effectively. I must say this, I was sitting there and thinking that these four colleagues and Dr. Vipul Singh and Abhishek of course and a few others, there was a High Court judge in Delhi who said something very interesting, and I feel like that very gladly. He said that in a court case, especially in a criminal case, both the lawyers, defense and prosecution, and both parties know very well what is the truth. They are not on trial. On trial is the judge, as to how well he is able to find out the truth. So I feel very glad and happy to have these four worthy colleagues judging me as to how well am I going to deliver the talk on depression to all of you. And I really would like all of them to comment on that later. But I genuinely believe in the concept of what V.K. Verma used to say, jury of peers. Your peer group is the best that judges you. Okay, and that's how I generally like begin a lot of my talks, especially about cultural current Indian society. That's the other reality. Okay, in that background, is there a tsunami of depression? You would have seen media articles, television episodes, so many suicides happening. And don't forget, especially among medical doctors, are young colleagues, JRs and SRs, right? So is there really a tsunami of depression? Unfortunately, one of the leading magazines in 2019 published a cover story. India is the most depressed country in the world. I know if some of you remember that. And while I collaborate with all these print and audiovisual organizations for awareness and education and more, I'm really troubled about this, even 5 or 6 years later. Because, and I hope you realize this, while what Ganesh Shanker said is very crucial, that there is a significant amount of prevalence of depression. Please be sure, India is not the most depressed country in the world. The serious error that this magazine made was going by absolute numbers. That time we were the second most populous country, now we are the most populous country. Obviously our numbers are the largest. The same thing happens in diabetes. There are big diabetologists in Delhi who get up and say, India is the diabetes capital of the world. It's not. Certainly don't do that for depression, and I'll tell you why. So this was the point that I want to begin with. You'll all appreciate you need to go by ratios, you need to go by prevalence rate and incidence rate, not by absolute numbers and population estimates. So while we want to recognize depression, please let's not be too carried away in that drive to this extent. And why? Please imagine young people, middle-aged colleagues, elderly, children, women, if you're already feeling slightly blue, if you're perhaps on the throes of depression, and then you read one such article in a credible magazine, what is likely to happen to you? You become more depressed and say, I'm not depressed, continue. That's the problem that this media guys sometimes do. Please be aware of that. But let's briefly consider why treat depression. Clinical considerations, be sure you can reduce significant individual and family suffering. And you have no idea how much. Prevent complications like suicide, and we'll hopefully have more time in the discussion. But one of the commonest complications of depression is suicide. One of the commonest reasons for suicide behavior is depression. So both ways, that is strongest link. What is not very well known is that for 30 or 40 years there has been very good research that keeps getting better about both humoral and cellular immune function being adversely affected by long-term or recurrent states of depression. And so once you have that, I mean, through HIV epidemic and the recent epidemic, we know how important immune system is. And so one of the very strong biomedically researched reason for treating depression is the effect on the immune system, especially of recurrent or chronic depression. The next most important reason, a whole lot of medical and surgical conditions, especially long-term medical conditions, NCDs, with fair amount of disability in different ways, is a very common concomitant of depression. And I'll talk about it more possibly, but please be sure that if you treat depression in the NCD or chronic medical condition, you improve the outcome of that medical condition. The commonest example that I think someday you might want to actually do a whole session on with these worthy colleagues here is the link between diabetes and depression. The commonest or any NCD, common condition, right? Very importantly, minimize the likelihood of relapse and recurrence. So some very good clinical reasons as to why you should never, any one of us in the medical community or in the society should miss out on finding out and diagnosing depression. But what are the public health or public policy considerations? One is the best strategy for suicide prevention. Early identification and treatment of depression will solve about 2/3 or 3/4 of the problem of suicide prevention. For better outcome of medical diseases, as I already said, to reduce the morbidity and the suffering, to reduce the indirect mortality because of the effect on the immune system. We never realize in public health terms what number of lives we are losing because we are not treating depression concomitant with medical illness. And of course, for increasing the productivity and meaningfulness of lives and communities. Having hopefully convinced all of you that it is necessary to recognize the correct nature of depression and see why you should treat it, let's see what is depression as a clinical condition. Please be sure, even if it's a repetition, not every experience of sadness or blues is depression. We all go through blues. We all go through periods of low mood or negative thinking or hopelessness. Not every experience of blue is depression, but sure, the subsyndromal depression is a very important concomitant condition with any medical condition. Oh, I have one more request that I forgot. I do not have the habit of reading out everything that's on this slide. So I'm going to request all of you to be a little more active both in terms of visual and audio inputs. So please look what's on these slides and I'll try and supplement what's there. With all respect, I do not believe in reading out everything that's on this slide. There are very important differences to be made between day-to-day blues or even transient sadness that any one of us may have with depression. What are the important things? Like I said, like Dr. Rashmi said at the start, thinking, mood, and action or behavior. The three parts of mental faculties. If there is negativity there, low mood, negative thinking, and reduction of activity level or initiative. That's important. 1 week or 2 weeks of continued depressed mood. Generally not related to events. सब कुछ अच्छा चल रहा है, सब बढ़िया है, life is good, LG is effective, and yet I am feeling depressed. You see a whole lot of clients doing that. And affecting different areas of life. So also don't make the mistake, and we will hopefully get time to talk about this in discussion. One danger, like I said about India Today article, one danger at a micro, meso or macro level is that in our enthusiasm to try and treat depression or identify and treat depression or mental health problems, we might overdo it. Please be sure, as medical community, it's very important to walk that correct line of identifying those who require depression treatment and those who are just going through day-to-day problems. Give them advice, give them support, let them go home. Don't over-diagnose, don't over-medicate. As you already said, like the three clinical tenets, three major factors for etiology and pathogenesis. Biological, psychological, social. Then there's one request, just keep indicating to me about time on this. You will all appreciate at least some of our senior colleagues will remember, 30 or 40 years ago, psychiatry and medical science diagnosed and classified depression in terms of the external and internal causes. Reactive depression, heartbreak, loss of money, promotion nahi hua, whatever, right? Divorce. Or internal biological depression, endogenous versus reactive. At some stage, 30 or 40 years ago, American psychiatry decided, and of course the world psychiatry followed, like everything else, including now, that it doesn't matter how the depression is caused. But the idea at that time was that if you have endogenous depression, you treat with medicines. If you have externally caused depression, you give them counseling, give them support, give them clarification, and it will become all right. What psychiatry realized, by and large correctly, with some caveats, doesn't matter where the cause of depression is, internal or external, endogenous or reactive. Very often there may be both, internal and external. But if the depression is above a certain level of severity, it requires treatment and can benefit from treatment. So what has been called as major depression. Now, is there a minor depressive disorder? Yes, it was proposed, but it has never went. So like many other medical specialties, if you recall, there will be major depressive disorder, there will be other depressive disorders. Not necessarily trivialize it by saying minor, but certainly recognize the importance of major depressive disorder, as the Americans call it, regardless of where the cause is, and benefit from both medicines or physical modes of treatment, others, ECGs or whatever, and psychosocial supported counseling. Now, the most important part is, and this is one of the things why I also think it's important to talk about why treat depression. A whole lot of elders or well-meaning people, including those life coaches and motivational speakers and spiritual gurus, with all respect to them, genuinely, would say, you don't need psychiatrists or medical doctors for depression. Willpower ठीक करो, खड़े हो जाओ, बात करो, काम करने लगो, सब ठीक हो जाएगा. सब ठीक नहीं होता. When a person is going through clinical depression, especially because of genetic or biological causes, that person, please appreciate, that person may be trying his or her best to overcome. He or she is not able to do so. I must tell you quickly, I don't have that slide, but I have a wonderful cartoon where two ladies are sitting on a park bench and one lady says to the other, why are you feeling sad and negative? Life is so good, everything is around, available, sab kuch hai. And the second lady turns around and says, why are you feeling breathless because of your asthma? There is plenty of air around. हवा तो बहुत है, तुम्हें क्यों breathlessness हो रही है? Please understand, that depressed person is terribly helpless after having tried. And then when any person in this society or you or I try and say, यार ठीक हो जाओगे, कुछ नहीं करना. It works very negative. So, like many other situations of life, if at all, and allow me to say this even as medical colleagues, if you do not know what to say, don't worry too much. But at least you should know what not to say. क्या नहीं करना ये तो एटलीस्ट ध्यान रखिए. उस डिप्रेस व्यक्ति को फिजूल की मोटिवेशन नहीं देनी. जो मुनासिब मोटिवेशन है वो दीजिए, मदद कर सकते हैं तो करिए, नहीं तो इन साथियों को भेज दीजिए. Please, know when to refer. I hope you are seeing this too. I hope you realize there are a whole lot of dangers to that approach of overcoming depression merely with motivation. We have already gone over this, but I want to say one more time. The immune suppression leads to repetitive infections of mild or serious nature, and this is often not recognized. Chronic or recurrent depression through immunosuppression, making a person susceptible to infections. Yeah, I hope you have covered this, but let me talk about figures, and you realize I have not talked about figures at all till now. What are the figures? Broadly, moटे तौर पे, lifetime expectancy that any one of us may go through depression as a clinical entity is 20%. Okay, so it's not very infrequent, like Ganesh has been emphasizing. What is the point prevalence or period prevalence at a point of time? at least 5%, if not more. And as the society changes, it can become more, 7, 8, 10%. So 1 in 5 chance that any one of us may go through depression. 1 in 20 that at this point of time, if we have 40 people here, certain number is clinically depressed, if we are representative of the general population. I have touched upon this, but please allow me one more time. Our own research some years ago established this very well. The clinical prevalence in a community sample for depression may be 5, 7, 8, maximally 10%. But what's much more important is subsyndromal depression or subsyndromal mental health problems in the community. That's about another 13 to 15%. So out of 100 people, if there are 7 or 8 or 10 people who deserve depression or mental health diagnosis and treatment, there are another 15 persons who have some syndromal symptoms who may not require diagnosis of depression, but especially in the interface between physical and mental health, that's very crucial. So whenever you see anyone with long-term recurrent surgical problems, or more importantly, long-term medical conditions or chronic medical conditions, please make sure that you screen for depression. Because you'll not only be treating the depression, but you'll also be helping improve that medical condition. Lastly, this. How to treat. Like it was said, previous session also was very nice, educating the latter part that I heard. Don't try and learn everything. Especially psychopharmacology has become too confusing, too far-ranging, and there's a whole lot of nuances. When Mahendra Saab, my senior colleague and friend, and when I started and a few others, if you remember, कहा जाता था कि तो psychiatry में करना क्या है यार, 4 diagnosis है, 4 दवाई है, कॉलम A और B मैच कर लो, है ना, जैसे एग्जाम में करते थे, वो सिचुएशन अब नहीं है. There is a whole lot of understanding of basic neurosciences, psychopharmacology, including epigenetics, for us to be able to choose medicines for depression, different patients differently. But for the primary care level or medical surgical colleagues, this should be enough. SSRIs, fluoxetine or escitalopram are good choices, at least for a period of 1 or 2 months or 3 months. Try that on your own. If it doesn't work, you might want to make a referral. Melatonin, non-benzodiazepine sleep promoters. The most common and effective one, zolpidem, right? If possible, avoid benzodiazepines, because that's not a great idea for a number of reasons. If you have time, we'll discuss. If at all, atizolam for short term. There's a whole lot of non-pharmacological management. I will not get into details. How is the time goes? Right. I'm just about to finish. Thanks. Yeah. No, because I really want more discussion with all of you. I will not get into details, but there is a lot of benefit of sleep hygiene education. For all of us, firstly, medical doctors ourselves, and of course our patients. Supportive therapy. I do want to say this very quickly, briefly. I was sure since my school days and my previous days that I want to go and get into psychiatry. But for a while in my internship, I was tempted to get into general practice, family physician. I sat with a family physician in Ahmedabad all through the year, 5 p.m. to 8 p.m. And for about 2-3 months, I ran his clinic. Believe you me, a good, effective, well-accepted family physician or any medical doctor in his or her own specialty is a very good supportive therapist. There is no big deal about supportive therapy. जैसा मैंने पहले कहा, firstly, if you know what not to do, क्या नहीं कहना है, क्या नहीं करना है, ये पहले समझ लीजिए. और उसके बाद be your natural self healer, physician, carer as good supportive therapy. I don't know if all my colleagues will agree, but supportive therapy कोई बड़ा हुआ नहीं है. Counseling and psychotherapy comes naturally to a good physician. And that's the point that I'm making. A whole lot of counseling and communication skills that I have carried for the last 40 odd years, I learned from that G in that 1 year. You know, I mean, I'm sure he is no more. He was much older than me. Okay. If required, Just for your knowledge, marital or couples therapy, cognitive or other high evolved therapies for which you make a reference to your colleagues. Practical do's and don'ts. Never forget to inquire about suicidal ideas and doing the needful. One big myth. And again, through our ICMR research, we have established this in very, very systematic manner. The fear that people in this society have, you all have, we have sometimes, is if you ask about suicide, will it trigger thinking or behavior? मेरे पूछने से क्या हो सकता है मरीज को फिर ऐसा करने का विचार आएगा? BS. It does not so happen. If the inquiry about suicidal ideas or possibility of behavior is made sensitively and with compassion, there is no increase of risk. But yes, you must know what to say and how to ask and how to support. If the person says, हाँ डॉक्टर साहब ऐसा होता है, मरने के विचार आता है, लगता है कि कभी अपने आप को मार दूं, and they will say, अच्छा कल क्या खाया था? You know, you ask about मरने के विचार आते हैं, हाँ जी डॉक्टर साहब होता तो है, अच्छा कल क्या खाया था? Bad. Doctor. If you ask about suicide, yes, please be sure how you are going to support if the person says yes. But don't avoid asking for that fear. Okay? दिमाग की बीमारी है mentally ये नहीं करिए अगर हो सके तो. Always, like I said, a good family physician is the best teacher for most areas of counseling. Lastly, I am nearing the end. Like this therapist says, and ये आज की सच्चाई है, जैसे मैंने शुरू में स्लाइड दिखाई थी, and the therapist is saying for those of you who can't read, well, John, in the past 2 years, you have gone from being extremely depressed to being basically unhappy, like the rest of us. My work here is done. तो जैसा जीवन है उसको जी लो, खुश रहो. If you want to set up, you can set up this. Thank you. Thanks so much. And be sure, really, get the email or the phone number, feel free to message. Thank you, sir. I leave that one for a while.
Thank you for the wonderful session. And now, house is open for discussion, question and answers.
Thank you, sir, for a nice talk. I want to know about the melatonin in insomnia.
I hope you all remember, melatonin is the pigment that decides our skin color. Africa, Europe, Asia, right? But it's also a very good sleep inducer. It will not help sustain sleep or maintain it for long. Two formulations available, 3 or 6 mg or 5 mg. The advantage is that I find this in my own work and through medical colleagues like you, very useful because people, rightly or wrongly, and we may not have time to get into, people do have a lot of fear about psychiatric drugs, especially sedatives, and rightly so, in half the cases at least. Melatonin is a natural pigment that you're going to supplement through external means to induce sleep. So, in a whole lot of cases for adjustment disorders, subsyndromal mental health problems, जिनको मेडिकल कंडीशन है, साथ में नींद नहीं आ रही है, क्लिनिकल डिप्रेशन अगर नहीं है, तो मेलेटोनिन मुझे लग रहा है, I don't know again how these colleagues see it, but melatonin is a good, okay, let me put it this way. What is my approach for insomnia? Step 1, sleep hygiene. Step 2, melatonin. Step 3, non-benzodiazepine sleep promoters like zolpidem. If none of this works, yes, I will go for a benzodiazepine bedtime sedative. Yes, please.
Hi. Oh, sorry. I just had a question here as well. Thank you for that talk. That was very good. What do you think is the biggest problem with trying to address the ignorance around mental health in India? It's a very broad question.
A few of us have been, and I'm sure these colleagues in the local context do the same. And if they don't, I will request them to do so. One example that a few of us are very fond of citing, and I'll go out on a limb and share that with you, is that depression or anxiety or any mental problem, especially depression, Why don't we consider that akin to a ligament tear or a small bone fracture or a tendon injury in my foot? Right? When you have a ligament tear or a tendon injury, you say, okay, I will not take POP, I will not take elastogram bandage, I will let it heal on its own. जैसे मैंने कहा ना, people say नहीं ये ठीक हो जाएगा, खुद हो जाएगा, अब ये will power से कर लो. Yes, you can do that. What are the problems? If you try and do a tendon injury or a ligament tear or a small bone fracture in the foot without any support, you're likely to be more in pain for much longer period. The recovery will take longer. There will be complications. Every winter you will have the pain. All that you need to consider is at least treatment for depression, anxiety, kind of common mental disorders as temporary support. Like POP does, like elastogram bandage does, like a crutch does. There's a temporary support for a few weeks or a few months, after which, yes, you get onto your willpower and your positive lifestyle and you don't need us. But if you start accepting psychiatry and mental health treatment as necessary for that brief while, important, second point, needing psychiatric help or taking treatment is not a sign of weakness at all. The commonest myth. In fact, it requires great courage to accept that I need help. And I have said this on television and radio many a times. To say that yes, I need help requires much more internal courage.
Sir, for elderly dementia, vascular dementia with some sleep issues, which is the safest drug that you can give?
मैंने कल शाम से सुना है आपके बारे में. देखिए आप सच में बड़े पेचीदा सवाल पूछ रहे हो. Thank you. No, I'm just
You
making a comment.
mentioned zolpidem. Is it safe in the say elderly people?
Yes, I would go carefully with the dose. I'll perhaps escalate from a very small dose, 2.5 to 5. Again, this colleague, I really would value their comments and people out there. But if there is especially vascular or mixed dementia, and I have seen far too many of them in many settings. If there is a behavioral disturbance, especially at night, I would think that quetiapine is a good choice. Amongst all the antipsychotics, surely avoid benzodiazepines as far as possible. Again, as a last resort, as we all know as physicians and medical doctors, in critical situations, I will do anything to give relief to the patient. So rare cases aside, where I will even use benzodiazepines, but rare cases, zolpidem, quetiapine among the antipsychotics. Bedtime, sorry, bad idea. Yes, sir.
Which of the antidepressants does not have erectile dysfunction as a complication? Which you will choose if patient is already having erectile dysfunction, and which one does not have the potential of causing ED? Which antidepressants should be used? Question number 1. Question number 2 is, you have described very well, sir, answers to 2 questions: how to treat, why to treat. The third question is, how long a patient of major depression should be treated? For 3 months, for 3 years, or for 30 years? How do you judge? How and what are the follies which the treatment is so prolonged on the base of the doctor or the patient, that some patients have become okay within 3 months and some patients are being treated for 30 years altogether?
Thank you. Great question.
I think we will, after this answer, sir, we
Wait,
will
close.
Thank
I know,
you.
right, thank you. I'll be brief. I get the hint.
No, but you will be able to
I
answer
know,
over tea.
Sure, of course,
Let
of
us
course.
tea outside,
Yeah,
everybody is
sure.
depressed, then please ask your questions outside. Thank you.
Second question, please be sure very briefly, there are recurrent depressive disorders. So there will be patients who will have recurrent depression every year, every 2 years, every 5 years. Okay? They possibly need treatment periodically or prophylaxis. There are cases of chronic depression. So in some cases it will be justified to even continue for long. But what's very important is, again, in psychiatry and depression particularly, long term, is what is called discontinuation exercise. If my patient for depression has been on antidepressant for 2 years or antipsychotics for psychosis for 2 years, Do I have the courage and the comfort to talk to the patient, take the family in confidence, and say, let us try discontinuation and watch? Can I make a very quick brief point with all respect to all the other medical colleagues? The major difference that again we use very often in clinics and public education is, in most NCDs, treatment is lifetime. Fortunately, in psychiatry and brain and mind problems, especially mind problems, medicines are not lifetime, it's what I call indefinite or long term. What is the difference? Discontinuation is possible. So at the end of 2, 3 or 5 years, have a dialogue, try and start reducing and see if the person remains well. If the symptoms recur, you go back on drugs, right? So please remember, and again I hope 4 of you agree, discontinuation exercise is possible. Treatment in psychiatry is very often long term, not lifelong. Whereas most medical conditions, it's per se theoretically lifelong. मरते जब तक दवाई खानी है, हम लोग डिसकंटिन्यू करने की जरूरत कर सकते हैं और करना चाहिए.
Thank you, Dr. Desai. This is going. Yeah.
Thank you, sir, for such a wonderful and covering all the topics of depression. बिन बूंदों के बारिश का एहसास कैसे होगा? जुनून हो दिल में जिसके वो हताश कैसे होगा? कार्यक्रम के इस अंग का मिजाज कैसा है? बिन ताली के हमें यह एहसास कैसे होगा? So please kindly give a big round of applause. Really motivates us.